Our topic, the efficacy of radial versus femoral access in the acute coronary syndromes. Is it the operator or the operation that matters? And this is a good one. This is a point of view that I wanted to point out to you. It is from JACC Cardiovascular Interventions, and it is in the September 2015 issue. And I'm with the author of the paper, who is Dr. Michel, who is director of the Regional STEMI program at the University of Ottawa Heart Institute in Canada. First off, what led you to write this particular point of view for JACC Interventions?
Well, I thought that this has been a matter of controversy now that's been around for a few years, and looking at the paper, I thought that there's some point of views that should be made.
Now, there was an original paper in JACC Interventions, correct, that started this whole thing off?
Well, in fact, this was there's been a number of papers that have been looking at the radial versus the femoral approach, and there was a previous paper published by Jolly in Lancet, and there was a companion paper that was published in, I think it was JACC or JACC Intervention by Mehta.
Absolutely. And your point of view really focuses on analyzing and discussing a large randomized study called Matrix, which compared transradial access to transfemoral access in patients presenting with ACS, who were referred obviously for PCI. We really have to start there. Remind us, discuss Matrix, and what did the study investigators conclude?
So this was a large randomized trial that was conducted mostly in Europe. The primary investigator was Valji Migli, and I think the authors did a very, very good job in a very difficult study to conduct in this setting. And what they did is, this study was fairly complicated in that it involved a comparison of radial versus femoral procedures in patients presenting with acute coronary syndromes. These patients were also randomized to two different doses of anticoagulants, two different anticoagulants, that is, bivalirudin versus unfractionated heparin. So it was sort of a bifactorial study, like
right.
So several arms, and then within those arms there were further design issues. So it was a very complicated study to do, and basically what they published their first paper, which was published in Lancet, and giving us the results of a transfemoral versus a transradial approach. For this particular study, they defined two co-primary endpoints, and the first co-primary endpoint was MACE, which are the major cardiovascular events, and consisted of death, MI, and stroke, and then the NACE, which consisted of the MACE outcomes plus bleeding. And the bleeding was defined according to the BARC definition, type 3 or 5.
So their conclusion was they came down along the sides of more radial access, correct?
The message that we get at the end when we read through the paper is that there was there was a superior advantage to using the radial in reducing the net adverse events, the NACE outcomes, and that was driven by a reduction in mortality and a reduction in bleeding.
And the mortality side of it is what got everybody's attention, because that's obviously a strong endpoint.
But that's got to be one of the hardest endpoints that we can find. Obviously, it's going to interest people. It's going to get people's attention. And interestingly, this is an endpoint that people have been feeling that may be the case. We saw the Rival trial when they looked at their sub-study of the STEMI population.
Right.
There was an absolute 2% reduction in mortality in favor of the radial approach in Rival. So Rival was another study of ACS that enrolled 7,000 plus patients. So it comes close second to Matrix. So this mortality indicator was kind of great interest.
But, and you had a bunch of buts that you wanted to bring out in your review. You warned that the results of Matrix must be interpreted with caution due to several limitations. So let's talk about those.
So let me highlight first that we're not trying to discourage people from learning. This point of view was certainly not to discourage people from learning how to do the radial approach. And I think that at the end of the day, I would say that any university program that teaches intervention must teach their residents and their fellows how to do both the radial and the femoral. I think what we need to know, I think at the end, is whether or not we should be using as a primary access the transradial approach.
One of the comments you made was that you were concerned about that they did not apply pharmaceutical strategies or report on the usage of vascular closing devices that may reduce bleeding.
So that was one of the points that we made in that there is some data, although I think there's not great randomized trials that have looked at this, but there is some data that would suggest that if you want to have a good comparison, that maybe you should be using a more modern strategy with vascular closing device. So, for example, in the Acuity trial, those patients that were treated with the closing devices had fewer outcomes. And if you look at Rival, they reported on the use of vascular closing device, and about 25% of the patients that got randomized to transfemoral, they used a closing device called Angiosil. And in this particular group of patients, the percentage of bleeds was identical, 0.7% in both arms, suggesting that you can sort of like balance the two groups. Furthermore, the use of closing device makes the whole femoral procedure more comfortable in that a patient doesn't have to have a clamp applied and can be mobilized much faster afterwards. So it kind of compares itself in some ways when people say that the transradial is a more comfortable procedure to undergo.
Now, in terms of radiation dose, because that's been another issue, and radiation exposure, it's a potential risk for interventionalists, should that be considered when evaluating one approach versus the other?
Okay, so I don't recall that in Matrix the radiation exposure was reported. However, falling back now again on Rival and looking at what happened in this 7,000 patient study, there was about a 2-minute difference per procedure, fluoroscopy time. So, you know, 2 minutes doesn't sound like a lot, but if you've got a busy interventional center, a cardiologist does 250 procedures a year, and you start doing the math, it adds up over a long career.
What I seem to take away is that primarily your analysis of the results clearly demonstrate that operator-centered experience is a key variable that's influencing the measured outcomes.
So in fact, I think that when you look, what drew my attention to was a figure where they exposed the outcomes on the basis of operator experience. So they had classified their centers as to whether or not they would do at a rate of like 15% to 64%. That would be the low group, the low radial operators, and the mid range was like 64 to 80%, and then above 80% to 98% use of radials. Those was the high radial operators. So they classified the results in these 3 subsets. And when you look at the low and intermediate use of the radial procedure in those centers, there was no difference in NACE or MACE. It was absolutely equal. And all of the positive results, the beneficial effect of the radial, seemed to come from the group of centers that had a very, very high use of the radial. And when you look at the data and you sort of look at the percentage, what's kind of bothersome is that, in fact, the rate of events actually climbs in the radial in those centers, and the rate of it, like, it goes from like 7-8% all the way to 10%. And when you look at the femoral group gets an astronomical rate of events in the range of 15%. So I think that sheds a bit of concern as to whether or not it is the operation or the operator. And people argue that, you know, a radial operator who was once a very great femoral operator hasn't lost his skill sets. But that may be not necessarily the case because the team approach is important, yes, right? And so, like, if you change your team approach and you get different group of nurses and technicians to help you out, remove the sheets and apply the clamps, the recognition of growing complications can be handled in a very different way as opposed to a center which does this on a routine basis. So although the operator may be skilled, his team may have changed, and so I think that that's something to highlight. It was categorized by center. So, and what defines the volume, the experience of a center is also the volume. A center that does big volume, and there didn't seem to be any relationship with the volume that the center did in that particular study.
Wow. Now, one last thing, in your opinion, and this is a point of view, so in your opinion, are the guidelines, as far as you're concerned, up to date? Is it time to look at the guidelines again? Where are we?
The data would suggest that we need to look at the radial approach and consider that all our universities should be teaching the use of the radial approach as well as the femoral approach. In my opinion, I'm not sure that we should say one over the other. I think that a lot of individualization is important. If you got somebody who comes in, for example, who's had previous bypass surgery, comes in with a STEMI, has had a RITA and a LITA, then I think the femoral approach may be the best approach. In patients who's shocky, sometimes the femoral approach is much better. And in that situation, if you don't know how to do the femoral approach, you're going to get into trouble.
But you're not yet quite ready to buy the whole concept of a reduced mortality.
I think that there is a need to do a mortality trial, and furthermore, I think when you look at Matrix was a very convoluted study involving many subsets, I think
I read your paper 3 times in order to make sure I got it all, because yeah, you're right, it's complicated.
And when you look at like they had 2 big populations in ACS. They had the STEMI population, they had the non-STEMI population, and you look at the results they got, it just go in opposite direction as to what they got in Rival. So in Rival, they showed a mortality benefit for the STEMI patients, and when you start looking at the direction that a non-STEMI took in Rival, there's a bothersome p-value at 0.08 for mortality for the non-STEMIs. And the almost exact opposite happens in Matrix, where the STEMI patients, the point estimate for the events, the NACE and MACE, seems to be right smack in the middle of unity, while the non-STEMIs seem to perhaps benefit a little bit more from the transradial. So I think that we need to look at a tighter group of patients, looking at, let's say, the STEMI population, and do a very well-controlled trial to look at each patient population individually.
I got to tell you, I really enjoyed your paper. So when I read it, I'm going, I've got to see if you're available. So thank you very much for your time. And the paper that we're discussing is Dr. Leday's paper in JACC Cardiovascular Interventions. It is September 2015. For CardioSource World News, I'm Executive Editor Rick McGuire.